Hi, everyone. Welcome to the Conversations in Interventional Cardiology. My name is Philippe Généreux, and I'm the Medical Director of the Structural Heart Program at Morristown Medical Center in New Jersey. I'm very honored also to be the guest editor of the SCAI special issue for heart failure publishing this year. So we're here today to discuss an important document published in SCAI entitled Heart Failure and Secondary Mitral Regurgitation, a Contemporary Review. I'm joined by an esteemed panel of SCAI leaders and experts. First, Gregg Stone, Director of Academic Affairs for the Mount Sinai Heart and Health System, Professor of Medicine, also in Cardiology. Linda Gilliam, my colleague, Chair of Cardiovascular Medicine for Economic Health System, Gagnon Cardiovascular Institute at Morristown Medical Center in New Jersey. And Amit Vora, Interventional Cardiologist, Assistant Professor of Medicine at Yale School of Medicine in New Haven, Connecticut. So first of all, thank you so much for joining us. I'm turning to Dr. Stone to start the conversation. I know you prepare some point to share on this important topic of secondary or functional MR. So Greg, why don't you go ahead with your presentation?
Well, thanks, Philippe. Pleasure to be here tonight and to speak about heart failure and functional mitral regurgitation. And I'm doing this on behalf of my co-authors on this systematic review that we did, Anton Kamaj from Mount Sinai, Vinod Thurani, and Linda Gilliam. So this is a really far-ranging paper that covers the impact and severity of secondary MR and its prognostic implications, how to best diagnostically image and diagnose the severity of secondary mitral regurgitation in heart failure patients. And then we spent a lot of the time talking about the different treatment options. First of all, how to stage and classify secondary mitral regurgitation to determine how severe MR has to be and how much it has to impact the patient's presentation before treating it should be considered. And then considering the transcatheter therapeutic options that treat secondary MR in patients who guideline-directed medical therapy is suboptimal. And that's really right now the transcatheter edge-to-edge repair with the MitraClip device. But there's a whole host of new devices that are being developed to treat secondary mitral regurgitation, most prominent of which is transcatheter mitral valve replacement technology. So we spent a fair amount of time talking about that as well. And underlying all of the assessment, diagnostic, and therapeutic decisions for the patient with heart failure and secondary MR has to be a superb multidisciplinary heart team consisting of cardiologists, interventional cardiologists, cardiac surgeons, imaging specialists, and other area experts that are really required to comprehensively evaluate and make the right treatment decisions for these very high-risk patients. So this just shows you that from some of the kind of key studies, the Cardiothoracic Surgical Network randomized trial of mitral valve replacement versus mitral valve repair in patients with severe ischemic mitral regurgitation, the COAP trial of the MitraClip versus control in patients with heart failure and severe secondary MR, and the MITRA-FR trial in this similar patient population, that if you look at just the rate of mortality at 1 year and 2 years, you see that take-home message is that these patients have a very poor prognosis. So you have on average probably 1 in 5 patients dying at 1 year, even with therapy, and double that rate in 2 years. So this is as severe a prognosis as many cancers. What you see from the CTSN trial also is that there were no significant differences in mitral valve replacement and repair, which was a surprise, actually, and the recurrent rates of MR were much worse with mitral valve repairs. So mitral valve replacement has kind of become favored for patients who are indicated for surgery for that condition. But surgery is rarely done for secondary mitral regurgitation and heart failure because there's no real evidence that it provides a prognostic improvement. In contrast, in the COAP trial, we saw that selected patients with severe mitral regurgitation and heart failure, but not end-stage heart failure, had a marked reduction in both mortality, heart failure hospitalizations, and an improved quality of life and functional capacity with a treatment of MR with transcatheter edge-to-edge repair with the MitraClip. A similar finding was not shown in the MITRA-FR study, however, and we believe for numerous reasons, but we believe the main reason is that they enrolled patients with worse left ventricular function and dilatation, but with not as severe mitral regurgitation. So the prognosis was more determined by the LV in MITRA-FR, where it was more determined by the MR in COAPT. So you can assess the severity of mitral regurgitation by transthoracic echocardiography. That's really the main tool. And we use a multiparametric method as specified by the American Society of Echocardiography, where the severity of MR can be classified as mild, moderate, or severe. And there's a variety of different qualitative and quantitative parameters that should all be considered that go into that determination. And of course, remember, secondary MR is a disease of the ventricle. The valve is relatively normal until late in the disease process, but you're really trying to get a sense of how impactful the left ventricular dilatation in most cases, atrial dilatation in some cases, have led to deformity or dislocation of the papillary muscles or annular dilatation, which leads to secondary mitral regurgitation. And this is a really important differentiation because only treating severe mitral regurgitation has been shown to improve prognosis. Many people will divide MR up into a 4-class scale, 1+, 2+, 3+, 4+, where 3+ is moderate to severe. And in the COAPT trial, both moderate to severe and severe MR patients benefited from transcatheter edge-to-edge repair. But you have to use this sort of multiparametric assessment. In the MITRA-FR trial, they used a much simpler method that at that point was in vogue in Europe that allowed patients with less severe mitral regurgitation to enter into the trial, and those patients don't necessarily benefit from MR correction. You can also stage patients with secondary MR according to their clinical symptomatology and hemodynamics, as to whether they're stage A, at risk of MR, stage B, have progressive MR, stage C and D have severe MR, but stage C is asymptomatic and stage D is symptomatic. And unlike asymptomatic severe degenerative mitral regurgitation, we have no indication today to operate on asymptomatic severe functional or secondary mitral regurgitation. So we principally will perform procedures or surgery only on patients with symptomatic severe MR or stage D patients. And finally, I mentioned today it's really transcatheter edge-to-edge repair that is dominant. The MitraClip is the only device approved in the United States for this treatment. There's a head-to-head non-inferiority trial, which is ongoing with the Pascal device. Some preliminary data have suggested that there may ultimately be non-inferiority shown. And so that device may be a second option for transcatheter edge-to-edge repair in the future. But there's a lot of other devices that have been developed, ranging from neocords to mitral valve spacers to posterior leaflet replacement technologies to papillary muscle slings, and many other clever devices. But really, transcatheter mitral valve replacement devices have gotten the most attention. And there have been more than 30 of these devices that were developed on the cusp of TAVR being so successful for aortic stenosis. And it's been much more difficult to come up with transcatheter mitral valve replacement in the mitral position for a variety of reasons, including the need for fixation, which is more difficult, a higher likelihood of paravalvular leaks and hemolysis, the risk of left ventricular outflow tract obstruction, and other complications that can occur. Sizing is a real major issue in choosing the right patients, so a relatively small proportion of patients have been eligible. Nonetheless, progress is being made, and there are single-arm and randomized trials ongoing to try to approve several of these transcatheter mitral valve replacement devices, principally for patients who are not eligible for transcatheter edge-to-edge repair, who have severe MR and heart failure. And this just really emphasizes the multidisciplinary diagnostic and management pathways to undergo, that patients should undergo. And I won't go through this line by line, but the bottom line is that when you have excellent diagnosticians, you want to assess, obviously, the patient's clinical status, functional capacity with 6-minute walk testing, transthoracic echocardiography to really assess the severity of mitral regurgitation. Sometimes that might be supplemented by echocardiography or magnetic resonance imaging as well. Many times you'll assess the structure of the mitral valve with transesophageal echocardiography and sometimes CT angiography as well, especially if you're looking for transcatheter mitral valve replacement. But the bottom line is you have to assess whether the patient has sufficiently severe mitral regurgitation, remains symptomatic after all class 1 guideline-directed medical therapies for heart failure that can be maximally tolerated. And as you know, there are 4 main classes right now that really do improve symptoms and reduce MR in these patients. And then there's the appropriate electrical therapies, that is implantable cardiac defibrillators and cardiac resynchronization therapy in appropriate patients. But if after all of those therapies, patients still remain symptomatic and have severe mitral regurgitation and meet COAPT criteria, then they should strongly be considered for the MitraClip therapy today, because that can reduce their mitral regurgitation and prolong their lives and quality of life and keep them out of the hospital. For patients who are not eligible for the MitraClip, there are some indications, such as maybe patients who have slightly higher pulmonary pressures than we usually would consider, patients who are difficult anatomy to clip that experts can do, or patients who are in shock or incipient shock. There's emerging data that these patients, many of whom were excluded from COAPT, may be successfully treated and benefited. We don't have randomized data, but we have registry data. But then there are other patients that should not be treated until we have more data, such as those who are asymptomatic with severe mitral regurgitation. And for patients who have real indications for treatment, but are just not amenable to the MitraClip, for example, there's too much mitral annular calcification, or the annulus is too small, or there are multiple irregular jets, then you might consider one of these newer approaches, in particular, right now, investigational study to enter the patient in for transcatheter mitral valve replacement. So it's a really exciting time, and we've made a lot of progress with the treatment of severe MR in patients with heart failure that are improving outcomes.
Gregg, thank you so much for summarizing your paper, and I have to congratulate you and your co-author, Linda, and others. A very comprehensive review that will be very useful for the readers. So thank you so much, Gregg. Now I have 4 little questions for you guys. First, Linda. Linda, you're an amazing clinician, also an imaging specialist. You're reviewing hundreds of echo a week through the core lab at Morristown. When you evaluate mitral regurgitation, what are the most common mistake or pitfall you see, and how can you mitigate them, or maybe use additional tool to complement your assessment?
So the first thing I'd say is that echocardiography is an operator-dependent technique. So you need to make sure that the images are optimized. And when we talk about assessing functional mitral regurgitation, that means having the sonographer really understand the importance of optimizing the machine settings and obtaining all the components that you need to perform the integrated analysis that Gregg referred to. He also made the point that we prefer to have images recorded by transthoracic echo with the patient awake. The reason for that is with TEE, the sedation that we need to use, particularly if it's propofol, can systematically reduce the blood pressure and will reduce functional mitral regurgitation. If you use propofol and the blood pressure falls, and this is your tool for assessing severity in addition to functional anatomy, you could consider using a pharmacologic agent that will raise the blood pressure back up to the range in which the patient lives. So you've got your pictures, and then you have to interpret them. And integration is important. The individual components can be discordant. And in patients with functional mitral regurgitation, you need to be aware that the methods that need to assume a circular orifice will tend to result in underestimations of the true severity. So those are the vena contracta, measured by 2D, as well as PISA-derived effective regurgitant orifice area and regurgitant volume. So the workaround to that is to record 3D views, and with an en-face view of the regurgitant orifice, you will see in many of these patients that it's not round at all, that it's actually quite elliptical, and you can simply planimeter that. Now, sometimes with echocardiography, some of the other components can be challenging, and one of those that can be particularly challenging is to be able to accurately calculate regurgitant fraction, which arguably is, if you had to pick one, this would be the one that you would pick. And I think that's where complementary imaging modalities come in. Certainly cardiac MRI we use frequently. It does provide accurate reproducible measures of regurgitant fraction and regurgitant volume. And while you're there, you're going to get a view of the ventricle and be able to see whether there's scar, for example. So there's other information that in terms of patient management can be useful, obtained with that technique as well. So use all the tools in your toolbox, I suppose, is the bottom line.
Well, let me ask, if I can ask you a question. What do you think of exercise echocardiography in the assessment of these patients?
I think exercise echocardiography generally is very helpful in patients with valvular heart disease. The applications fall into two general buckets. Either you have someone who looks like they've got a lot of MR, bad ventricle, and you think, my gosh, these patients have to be symptomatic, but they say they're not. And not infrequently, when you exercise those patients, they declare themselves as having very, very limited functional capacities because it's something that's kind of crept up on them, and they may not be aware that they've really ratcheted down what they attempt to do. But the other thing that you can sometimes see is that MR that doesn't look to be too bad at baseline, when you exercise people, it will declare itself as being actually quite bad with exercise. And those patients are typically those who are symptomatic, and you're having this disconnect between the symptoms, typically a bad ventricle, and MR that doesn't look so bad at baseline. So a stress echo can be very helpful in seeing whether or not you can uncover more severe MR to make the whole picture fit together a little bit better.
All right. Well, Linda, thank you for those tips and tricks. And I have to tell you, I'm a specialist for aortic stenosis, and I can make my own diagnosis. But for MR, I always end up calling you or one of your colleagues to make sure it's severe or moderate, or what is the mechanism. So now, Greg, I'm going to ask you a very important question. Let's say Linda confirmed the MR is severe, functional MR. Now it's time to apply the guideline to go with the good medical therapy, or what I should say, the guideline medical therapy. One question is, how far should we push GMT, and what should we expect in 3 to 12 months? And maybe talk about the experience you had in COAPT, where everyone had a very compulsive review of the medical therapy, and also in contrast to mitral FR. What to expect with GMT, and how should we push it?
Yeah. Well, there's no doubt that, GDMT, which is beta blockers, inhibitors of the renin-angiotensin system, in particular, neprilysin inhibitors, if the patient can tolerate them, mineralocorticoid receptor antagonists and SGLT2 inhibitors are very effective in heart failure in general, and decrease mortality, decrease heart failure hospitalization rates, improve quality of life, et cetera. And several of those agents have also been shown to reduce secondary mitral regurgitation, particularly by shrinking the ventricle. And cardiac resynchronization therapy will do it too, and also increases the closing forces of the mitral valve and has some direct effects. So I do believe that it's very reasonable to try those agents first. And you do need to try to push maximal doses, in particular with beta blockers. It's a very dose-dependent effect with beta blockers. And it's still debated somewhat whether you should, with a new heart failure patient, do sequential or simultaneous initiation of these agents. But, the STRONG-HF and other studies are now showing that you really can initiate these agents near simultaneously and accelerate their dosages in a relatively aggressive format. So by 4 to 6 weeks, you're going to be able to find out of those 4 classes, which ones they can tolerate and to what maximal dose. But it so turns out that patients who really do have, bad left ventricles and severe mitral regurgitation, they have a lot of comorbidities. They have chronic kidney disease. They're prone to hypotension, hyperkalemia, and other contraindications. So they often can't tolerate these agents. And in COAPT, what you were alluding to is that before we randomized patients, we had a central eligibility committee consisting of heart failure specialists review with the presenting physician all of the guideline-directed medical therapies, and patients had to be on truly maximally tolerated doses of each of the, at that time, 3 classes. The SGLT2 inhibitors weren't approved, and before enrollment. And we did that, and the patients that got turned down because they weren't on maximal doses, we said, try to push their medications, and if they still remain symptomatic and have severe MR, come back to us. And we didn't, my big regret is that we didn't systematically collect that experience, that non-randomized experience. But I would say that approximately a third of the patients never came back. Some of those patients may have died, but I think most of them actually got better. The MR went down to moderate, or they became asymptomatic on better medical therapy. So heart failure specialists can add a lot to these patients. But a lot of the patients can't tolerate, these drugs because of the multiple comorbidities and how sick they are. And so while most patients can tolerate some dose of beta blockers, it's rarely a maximal target dose, like 200 milligrams of metoprolol is the target dose. And a lot of the patients can't tolerate Entresto or MRAs. And so we end up getting a lot of patients that they're on moderate or mild doses, and they're on 1 or 2 or sometimes 3 of the medications, but rarely on all of them. They're not doing well, and then they really can respond very favorably to reducing their mitral regurgitation.
Yeah. Well, and what about the CRT, Greg? So what was the proportion of patients that get a CRT in COAPT?
Yeah, well, again, we had, approximately, as I recall, about 35 or 40% of the patients enrolled had CRTs, but they have failed CRTs. They're a high-risk cohort. Lancelotti and others have published on this, that if you continue to have severe MR and symptomatic heart failure despite CRT, you are a high-risk subgroup. And those patients did quite well with the MitraClip, equally as well from a relative point of view as patients who did not have CRT. And relatively few patients, certainly few patients after the MitraClip, develop progressive left ventricular function with new left bundle branch blocks, wide QRS, et cetera, that needed CRT during follow-up.
Yeah. All right. So, Amit, a question for you. Now, Linda says it's severe. Greg, maximize the medication. Now the patient is on your table. There's 2 tools available now. There's a MitraClip, which is approved for functional and degenerative, and there's a PASCAL, which is approved only for degenerative. Can you share your experience with those techniques, those 2 approaches, actually PASCAL and MitraClip? Do you use one more for certain anatomy, for example?
Yeah, no, absolutely. Thanks very much, Philippe. I think that it's always great to have more tools in the armamentarium. And I think a big advantage to Pascal before the current generation of MitraClip came out was the independent leaflet grasping. And so in the prior version of the MitraClip system, the third generation, we did not have individual grasping available, and that was a big advantage for Pascal. There are a couple of other interesting design elements for Pascal, which I think make it compelling. One is that there is a central spacer, which the thought at least is that that can help to bridge the coaptation gap. The other is that if you're unhappy with the position of the device in the ventricle, with the MitraClip, you have to invert the clip and then bring it back into the atrium. And sometimes it can be challenging. You can get caught in chordae, that sort of thing. With Pascal, there is an elongation mechanism that really allows you to bring it back into the atrium much more easily. I think that the jury is still out as to whether Pascal will be just as good as MitraClip in secondary MR. That trial, Pascal 2D, is currently, or CLASP 2D rather, 2F, CLASP 2F is the functional MR. It's ongoing, and so we'll have a better sense. In my experience, I think that at least for primary MR, Pascal, and especially the newer Pascal ACE device, which just has a thinner profile or slimmer profile, can be useful in folks that have more commissural MR, where you're really worried about getting caught in the cords. But in general, I think both devices are excellent and will continue to get better in subsequent iterations.
I think that's really interesting, and like you said, class 2F still out, so we're going to see. So I want to give you the last question, Greg. You alluded this in your slide about TMVR. We have two good options in TEER, pretty safe. At least one is in the guideline. What will it take to see TMVR get approved or get in the guideline? It seems that it's been a long journey. What type of study will you need to get into the guideline and get approved, actually?
Yeah, so that's a complex and somewhat evolving question, and I think you've got to basically divide it up into COAPT or TEER eligible patients and ineligible patients. I mean, the results of TEER have been, so astounding, frankly, better than we could have imagined. And TEER is an extremely safe procedure. It's one of the safest things that we do in the cath lab. Again, it does not eliminate mitral regurgitation in most patients, but it markedly reduces it, and that improves outcomes. Transcatheter mitral valve replacement has the capability to 90+% or greater patients totally eliminate mitral regurgitation, and it can do it very reproducibly. And in the right patient, it can be actually a simpler procedure than the MitraClip. But finding the right patient, again, is a challenge, and the complications are somewhat predictable, but not always predictable. And in general, the complication rates have been substantial, although I think we're still in the learning curve with TMV big R. So for COAPT eligible patients, I think that given that the safety profile is likely not to be as good as with TEER, then you probably need a more effective therapy. And it's not just effectiveness in reducing mitral regurgitation, it's clinical effectiveness. So, and that's a pretty high bar, because the MitraClip basically has reduced mortality and heart failure hospitalizations by 50% in these patients. So I think the wider use is going to be in patients who cannot be treated with the MitraClip, and there are many such patients. And interestingly, there are 3 trials that are going on now, with transcatheter mitral valve replacement systems. Only one of them has a randomized arm, and that's with that's in the Summit trial, in which they're comparing MitraClip eligible patients to the MitraClip in a randomized fashion, MitraClip ineligible patients to the Tendyne device without the MitraClip. The other two trials, including, the one that's farthest along is, Apollo, with the Intrepid device. Interestingly, they are single-arm studies. And, so the outcomes we know are going to be poor in these patients, even if they're improved. And so I don't envy the regulators and guidelines committees that are going to look at the outcomes from a single-arm study in, again, coapt ineligible patients treated with transcatheter mitral valve replacement to try to have a sense of whether those are reasonably safe and effective outcomes warranting approval and guidelines. So I'm hoping that the results are just outstanding. So it'll be a very, very clear determination, but I suspect it'll be more complex than that.
Yeah, well, I cannot agree more. I think the reproducibility and the predictability of the MitraClip or Pascal, the tier in general, is such that it will be hard to beat. But there's clearly an unmet need. At least 50% of the patient are not candidate to MitraClip. So, like you said, extremely exciting field for now. So, all right, I think we're way past for 15 minutes. That was a very exciting discussion. Thank you again for your great manuscript, very useful and comprehensive paper. So I want to thank the speaker, the panelists, and also the SCAI member for watching us. Thank you so much.